Now, let's look at a couple cases, or one case here. So this is somebody who obviously has what angiographically looks like a pretty significant stenosis in the mid-LAD. It was stented. The final angiogram is on the right. Reasonably good result, I guess, angiographically. And so this is how the physiology breaks down. IFR was very, very impaired in this vessel, 0.28, so obviously critical amount of ischemia. And post-PCI, it improves to 0.68, so it's a lot of gain, if you will, from a physiological standpoint. But clearly, this vessel still has residual ischemia. And so when we now do this pullback, which is shown at the bottom, one can see that there is a step up distally of 6 units. So there is a focal lesion distally that was missed. The stented segment has a focal step up just proximal within the stent of 5 units. And then there is a big step up, a big gradient proximally of 11 units. So really, there is 3 individual focal lesions that were left behind that were inapparent on the angiogram.
Right, so importantly, we're seeing these 3 stepladder effects. We're not seeing a diffuse straight line, which would mean diffuse disease, but we're seeing 3 kind of focal areas that you need to be concerned about.
And another thing that's really evident on this angiogram is that often we're fooled by proximal disease that may be tubular and diseased in that space.
Right.
And when it's proximal, it's having a bigger effect often.
Right.
So your eye's not spending that time. And when you look at this angiogram and you then see the physiology says there's 11 units in that proximal segment, it would certainly make you want to go back and take a look, at least at bare minimum, at that spot of the angiogram and maybe change your practice.
I think that sending this patient home, right? This patient came in, I assume, with angina. You know, they would be leaving the cath lab with an IFR of 0.68. And as you said, you got a pretty significant step up from 0.28 to 0.68. But this is how we should be thinking now, right? We're always thinking about, oh, the patient had a 90% stenosis, I put a stent in, 0% stenosis, excellent result, right? That's what everyone writes. Now we've got to get more prescriptive. We have physiology to guide us. So yes, you've gained 40 millimeters of mercury of IFR unit, but you're leaving the lab with a significant gradient, a lot of which is in the very proximal LAD, as you said, which
and how
potentially could be addressable.
Right.
So we'll talk about the implications and how we should start reacting to this. Once we really, let's see all the cases first, and then we'll talk about how much data do we have and evidence do we have to have us act now versus what kind of new evidence do we need to generate in the future before we can make sweeping recommendations. So go ahead.
Just
Alan.
one more point to Habib's comment. I think what will be interesting in the follow-up phase, because remember everything was blinded, so we will follow these patients out. We will see what is more important, the amount of residual ischemia or the amount of IFR gain. And in this case, that's actually a great example of that, which we don't know how this patient is going to fare. All right, so this is another example. This is a in-stent restenosis. There's a stent in the proximal to mid LAD, and I don't know if you guys can make that out, but just distal to that diagonal branch, it seems like there's a pretty significant in-stent restenosis, which was treated with another stent. The final angiogram looks very good. Let's look at the physiology. So in this case, initially there was ischemia. IFR was 0.86, so it's below the ischemic threshold. Not as much ischemia as in the other case, but nevertheless. After PCI, it actually went down a little bit to 0.84. I would say basically no significant change. And then on the bottom right, when we do that pullback, what we see is this pattern of more diffuse disease, right? Throughout the stent and proximally, that in this patient, in fact, the stent didn't make any difference at all. You can make even the argument it decreased IFR slightly. But the bottom line is this is now diffuse disease we're dealing with, and maybe those patients need to be treated a bit differently than somebody with a focal lesion.
Now it looks like there may be one focal area in the distal part of the vessel,
right.
And how additive is this? If we were to think in our minds, if we could eliminate that 0.04 step up, would we expect again get a 0.84 IFR?
0.88.
I'm sorry, 0.88
yeah,
IFR, yes.
I think so. I mean, there's actually a pretty good
Right.
study that was recently published exactly on that point, is
Right.
how predictive is it? And because we talked about this before, this is not with hyperemia where there is so much crosstalk. The crosstalk is pretty minimal under resting conditions.
Exactly.
You can actually predict your outcomes. So yes, in theory, you could, if you put another stent, you can gain 4 points. Now, if you want to do that or not, I think is a very interesting question. But that's more a clinical decision.
Right.
At least you have the data, which is step
Right.
number one.
All right, and let's see the third case, and then let's talk about this fascinating concept.
All right, so this is another case here where we have what appears to be either a distal left main, you can see on the right, or ostial LAD stenosis. Difficult to see, I think, in the absence of an LAO caudal, but nevertheless, what appears to be a pretty significant lesion, again, distal left main ostial LAD. It was treated with one stent from the prox LAD back to the left main. Angiographically, I would say it's a spectacular result. You can't ask for more than that. Now, physiologically, the IFR was 0.83 going in, and believe it or not, it was 0.83 coming out. And the pullback indicates that there is basically step up both distally and proximally to the stent. So proximally to the stent is basically in the stent, as well as a focal area of a pretty significant step up just distal to the stent. So it's really interesting to see how deceiving the angiogram is. Where you think the lesion is actually might not be the case when you do this pullback and you understand the distribution of plaque and the lesions based on physiology.
So these are fantastic examples, and I mean, it makes very convincing the results that you showed with almost a quarter of the patients having residual ischemia as defined by IFR after these otherwise superb-looking PCI results. It's distressing, actually.
It is.
And again, the fact that, you know, about 4 out of 5 of them are focal, you know, when you hear the word focal as an interventional cardiologist, it makes you think, well, that I can do something about that. So let's start talking about the implications.